Thanks very much, and thanks for coming to the presentation. So what I want to really talk about is a bit of background about the virus itself, including natural history, what it does, some epidemiology, testing, which a lot of people find a little bit confusing, and also fibrosis assessment, which is key to to assessing a lot of our patients. Okay, so what is hepatitis C? Basically, it's a virus that belongs to the Hep C virus genus within the flavivirus. So the flavivirus family is a virus family that is best documented by yellow fever. So it's actually in the same group of viruses as yellow fever. It was first identified in 1989. So before that, you may remember, those of you who are as old as I am, that it used to be called non-A, non-B hepatitis. So I used to do hepatitis A serology, hepatitis B serology. If it was negative for both and you couldn't find an alternative explanation, that was non-A, non-B hepatitis. So as it turned out, when the virus was identified, most of the cases that were non-A, non-B, particularly those that were transmitted by blood-to-blood contact, ended up being hepatitis C. It's obviously a virus that primarily affects and damages the liver. It's mainly transmitted blood-to-blood, and we'll go into transmission mechanisms in a moment. And it has the potential to cause cirrhosis, liver failure, and liver cancer in certain patients. So let's talk a little bit about transmission, and there are certainly certain myths around transmission, so there are certain aspects that I really want to cover. So the most common type of transmission is percutaneous, so blood-to-blood transmission. And the most common way of transmitting hepatitis C is through injecting drug use. So if you use consistently for 3 years or longer, your chance of having hepatitis C is about 70%, or 70% of patients will be Hep C infected by that time. And it accounts for over 80% of Hep C infections in Australia. So that is the most common, but not the only way of transmitting Hep C. In the past, there are still some patients around that got it through blood transfusion or blood products. It's now vanishingly rare. What we do now is we use NAT testing, nucleic acid testing, for our blood products. So the current estimate of transfusion by risk of transfusion by blood products is about 1 in 4 million units. So it's incredibly rare. But there are still people around prior to when screening started in 1990-91 that are infected, and you might find some older individuals such as women who had a postpartum hemorrhage, needed a transfusion, or trauma victims, as well as certain haemophiliacs who are still around who are infected. Other percutaneous modes of transmission, tattoos and piercing, which are incredibly rare. Particularly in the current era, most tattoo parlours and piercing parlours are very well credentialed and use safe practices, but some of the old backyard jobs still occasionally transmit. There are therapeutic mechanisms of transmission through contaminated equipment or unsafe injecting practices. It used to happen a bit in dialysis centres, so some renal patients got it. And there were certain medical procedures such as vaccinations in some countries that transmitted Hep C. The best known of those is the schistosomiasis vaccination program in Egypt in the 1950s, which resulted in a certain part of Egypt having a prevalence rate of 40% as a result of that. There's occasional needle stick exposure. The risk of a needle stick, it's said 5%, but it's actually less than 1%. That's an error. So the rate of transmission is actually quite low. The other way of transmitting is through permucosal transmission. The most common way of permucosal transmission is mother-to-child transmission. So if a mother is viremic and has hepatitis C, the risk of transmission to the baby is 5%. So the odds are with the baby, but it's still possible, and follow-up needs to be performed in that baby. The other issue that's always talked about is sexual transmission, and this is where a lot of confusion reigns. Really, the only efficient population in which Hep C is sexually transmitted is in HIV-positive men who have sex with men. In other circumstances, it is incredibly rare. And this is a study that shows you how rare it is. So this was a large study of almost 1,000 monogamous heterosexual couples, of which one of them, so they were discordant, one of them was Hep C infected and was viremic, so that they were RNA positive. And they had over 8,000 person-years of follow-up. So a long study, and the vast majority of those patients were followed up to 10 years. The patients were advised not to have any anal intercourse or sex during menstruation, but they clearly did not use condoms. So in total, there were 3 infections over that whole period. One had a different genotype, so clearly got it from someone else. The other two had the same genotype, but also had a different virus on phylogenetics. So all three came from outside the relationship. And that really tells you how rare sexual transmission is, and the fact that we don't need to use safe sex practices purely on the basis of Hep C. So this gives you an idea. This is Australian data looking at the risk factors for newly acquired hepatitis C, and you can see injecting drug use accounts for about 82% of cases, sexual transmission 2%, tattoos 2%, and there's a rag bag of unspecified or other that constitutes the other 14%. So let me now move to how you make the diagnosis. So diagnosis is made on the basis of three different types of tests. First is Hep C antibody test, so serology. Second is Hep C RNA test, usually by PCR. And the third and the most characteristic indicator of active liver disease is an increase in the ALT. So when you diagnose someone, one of the reasons you'll do it is because you think they're at risk. The other is because they've got abnormal liver function tests, and that's part of the screening process to find out why the LFTs are elevated. So let's take each of those individually. So serology. Serology is the cornerstone of our testing. So what the Hep C antibody does is it detects that the immune system has actually seen the virus. It does not tell you that that patient has current infection. For that, you need a PCR test. There's a delay in appearance in someone who's acutely infected. So if you've got someone with recent acquisition of hepatitis C, they're not always seropositive by the time you actually see them. So you have to be careful. If you suspect acute Hep C and they're antibody negative, you might need to do a PCR to confirm that. So that's kind of a trap for young players. The other test that actually tells you that someone has active virus replication is the RNA test, known as commonly as the PCR, because that's the technology used to detect the Hep C RNA, which is the genetic material of that virus. So it directly detects the virus, and there are two types of PCR tests. There's a qualitative test that basically says yes, no, and is usually the standard to determine whether a patient is viremic or not. And if that's detected, you then go on and do a Hep C viral load and a genotype. The second type of test is a quantitative test, which tells you the amount of virus in that person's blood. So it gives you a viral load result, and that's expressed in international units per ml. So you'll see viral loads expressed in this way if you ever get a result. Now, previously we used to use viral load pre-treatment and also during treatment, particularly to predict response to therapy, but that's largely disappeared, as probably Alex will tell you when he does his presentation. So this is the recommended testing algorithm if you want to test someone for hepatitis C. So your first test is an antibody test done by an EIA, which is a screening test. If that's negative, the patient is deemed to be uninfected and you stop. If that is positive, there is a second confirmatory EIA done. If that is negative, then there's a discrepancy between the two tests and it goes off to a reference laboratory, and the issue is there are some false positives built into the system, because when you do a screening test, you try and pick up everybody at the cost of occasionally having a few false positives. If both tests are positive, that patient is deemed to be potentially infected, and then you link them to care and follow up with a PCR to see whether they've got virus on board. So the interpretation is as such: if they're antibody and RNA positive, there's no evidence of infection. If they're antibody positive but RNA negative, it's probable resolved infection, but the other explanation is it might be a false positive, as I've told you. And if both tests are positive, then you've got current active hepatitis C. So the next question is, who do we test? So these are the recommended groups that we test. Firstly, people who inject drugs currently or who have ever injected drugs, sex workers, people in custodial settings, people who have had tattoos or body piercing, people who have received a blood transfusion or organ transplantation before 1990, getting back to the point of transmission mechanisms that I alluded to before, children born to Hep C infected mothers, sexual partners of a Hep C infected person, people who are infected with another bloodborne virus such as HIV or hepatitis B, people with evidence of liver disease, so persistently elevated liver enzymes, people who've had a needle stick injury, and migrants from highly prevalent regions, such as Egypt, but also parts of the subcontinent and Southeast Asia, given that there are unsafe practices that have occurred potentially in those jurisdictions. So the other thing is, if you look at the cascade of care in Australia, what you see is that there's about 230,000 total Hep C infected patients in Australia by the estimates that have been done by the Kirby Institute from Sydney. Of those, we've done a reasonably good job at actually diagnosing them. So 75% of those cases have been diagnosed. The damning statistics is on the right-hand side. So what you can see is that 20% of patients have ever been treated and about 11% are cured. So we've got a long, long way to go to get those patients into care, treated and then effectively cured. And as Alex will tell you, with the current treatment regimens, that's a revolution and it's highly likely to occur. The other aspect of hepatitis C is genotypes, which sometimes confuses people. Genotypes are basically different strains of hepatitis C, and they differ by a certain amount of nucleic acid differences. They're important for two reasons. One is there are certain genotypes that are specific to certain parts of the world. So if you get someone with a slightly rare genotype, you can usually get an idea where they come from. So if you look at genotype 4, for example, you can see the majority of those cases occur in the Middle East and the Horn of Africa. If you look at genotype 5, it's pretty well around the area of South Africa. And if you look at genotype 6, that's the Southeast Asian genotype. In all other jurisdictions, it tends to be a mixture of genotype 1 and 3, and that's certainly the case in Australia. So these are the genotypes broken down. We have a reference laboratory called Vidril that is located with us at the Doherty, and you can see that by far the most common genotype in Australia is genotype 1. It's the one that used to be called the difficult-to-treat genotype when we only had pegylated interferon and ribavirin. Genotype 3 was considered the easier genotype and it accounts for 37% of our cases. So in fact, over 90% of our cases are either a 1 or a 3, and there's a smattering of the other genotypes. So those two predominate in the Australian population. And as Alex will tell you, their treatment is different. In fact, now 3 is the harder to treat genotype, so the roles have reversed. Clinical presentation, most of the time it's completely asymptomatic, but you can get occasional cases of symptomatic acute hepatitis. For that, the incubation period's roughly 7 weeks. It ranges between 4 and 20 weeks, and it's a typical presentation of any acute hepatitis with fatigue, abdominal pain, jaundice, but it only occurs in about roughly 20% of individuals, which means 80% of individuals seroconvert relatively asymptomatically. Chronic infection is largely asymptomatic. This is a silent disease. It's a bit like having high blood pressure, sometimes only picked up until the sentinel event right at the end occurs when the patient develops liver failure. There are some symptoms that patients consistently report, and I think we believe that they're real, that patients consistently have fatigue and cognitive impairment. Occasional patients also have extrahepatic manifestations which are immunological, such as a leukocytoclastic vasculitis and a glomerulonephritis, but they're actually not that common. So I mentioned that some patients actually recover with acute hepatitis C. That happens in about 20% of cases, and what you can see here is the pattern of someone that gets infected and then recovers and spontaneously clears their virus. So what you can see is the ALT in black has a nice spike. Patients will go up into the several hundreds or even a couple of thousand ALT levels. The RNA becomes positive very quickly after a week or two post-infection, but as you can see, if they clear virus, the RNA becomes negative. There's a delay in antibody production because there's a window for antibody, and the antibody eventually becomes positive. So what you get is someone who's antibody positive, RNA negative, like we talked about earlier. And that's opposed or contrast with someone who has chronic infection. And again, I get that spike of ALT. The ALT doesn't normalise like it did in the last case. It bounces around above the upper limit of normal, but it comes down significantly to about between 50 and about 200 ALT generally. And the virus RNA remains positive throughout. So they're chronically infected, and again, they mount an antibody response. So that's how you tell someone who's got chronic infection versus spontaneously resolved. The natural course of infection, as I told you, about 20% of patients spontaneously clear, but that means that 80% don't. Of those with chronic infection, about 80% remain relatively stable. This is for the most part, a slowly indolent infection that causes problems by attrition over a long period of time. So over about 30 to 40 years, on average, about 10 to 20% of patients will develop cirrhosis, and about 4% of those will die of liver failure, 1 to 5% will develop liver cancer, and of liver cancer, 33%, or a third of them, will die in the first year. So not everybody gets into trouble, but certainly a significant number of patients do. The other thing to say is the ALT can be normal in this condition despite having chronic infections. So this is a study where they looked at 2 years of follow-up with a minimum of 4 ALT measurements over that period of time in patients who are viremic. And you can see 40% of those patients had a normal ALT, 43% had an intermittently elevated ALT, and only about 15% had a persistently elevated ALT. So the message is, if you have a normal ALT, it doesn't mean that patient doesn't have chronic infection. The other thing is that I told you in general it takes a long time for patients to run into trouble and develop cirrhosis. There are certain cofactors that make this progress faster. And more rapid progression of fibrosis to cirrhosis will occur if someone drinks excessively, if they're male, if they're co-infected with another blood-borne virus, be it HIV or hepatitis B, or if they have obesity and they have NASH, so non-alcoholic liver disease. So these are factors that make things move a little bit more quickly. The counter is people have slower progression if they're females. Males progress faster than females. If they're younger, there's something about an older liver that makes it progress faster. And patients with persistently normal ALT tend to progress slower than patients with elevated ALTs. And this gives you some data on the effect of alcohol. And this looks at patients who have F0 to F1 fibrosis versus F2 to F4, 4 being cirrhosis. So mild or no fibrosis versus significant or advanced fibrosis. You can see the group that drinks between 30 and 50 grams of alcohol per day has a significantly higher rate of F2 to F4 fibrosis than those who have F0 to F1. So what's the burden in Australia? How are we placed in terms of actual disease? So these are modelling estimates done by Bill Sievert and his colleagues as to what the situation was like in 2013. And you can see in that year there were 530 deaths, 590 liver cancers, almost 1,500 patients decompensated or went into liver failure, and there were almost 14,000 cirrhotics and another 30,000 who had F3, which is advanced fibrosis. So the burden of the disease is considerable, it's not minimal. They then modelled what would happen if things stayed the way they are and what would happen in 2030. So this is 17 years down the track. So the actual number of cases didn't go up that much. It went up to 251,000. But what you can see is the number of deaths trebled, the number of liver cancers almost quadrupled, and the number of decompensated patients also trebled. So if we don't do anything about what's happening now, we're going to end up with a bigger burden of disease on the severe end of the spectrum. And that brings us back to the same slide I showed you earlier, that very few patients, or only 11% of our patients, have been successfully cleared of their virus. And this is a virus where you can actually cure the infection. Unlike HIV or hepatitis C, this is a curable virus. So this slide is important in terms of increasing the number of people we need to treat. So the same people that showed you the models of the amount of disease in Australia then looked at what would happen if we actually increased the rate of success but kept the number of patients that we're treating the same, and then increase the number of patients we treat but do it in two different ways. One, in general, increase treatment numbers, and secondly, particularly focus on the ones that have advanced fibrosis, those with F3 or F4 for the first 2 years. And what you can see, if you just increase the response rate of the treatment that you're using, you virtually have no impression on any of those parameters, whether you look at number of infected cases, the cost, rates of cirrhosis, decompensated liver disease, liver-related deaths or liver cancers. You do nothing. If you actually increase the patient numbers, whichever of the two strategies, whether you treat everybody or concentrate on the advanced liver disease, that's when you actually have an impact on disease on all those parameters. So what this tells us is that we really need to get more patients into care, which is why you guys are here. Which brings me to the next issue, and that is fibrosis assessment. So we need to know at what stage of fibrosis or how much scarring these patients have in their liver, because it's important in particular to know if they have cirrhosis or not. So the model of care is changing, and you guys are going to start, well, some of you are going to start prescribing. So we're going to have to decide who stays with you and who comes to us as specialists. And the most important indicator to refer in is if you have cirrhosis. So you need to be able to pick patients who have cirrhosis. So there are several ways you can do that. You can do it clinically, so if the patient's got spider nevi, if they've got splenomegaly, if they've got ascites, but it's very crude. It's only really at the end stage of their disease that that'll become apparent. You can get some indications from their blood tests. So if you do an FBE and they have a low platelet count, to us, if you've got a Hep C patient, that almost always means they're cirrhotic because they've got portal hypertension and the platelets go down. So if you see low platelets in the setting of Hep C, the first thing you think of is that that patient might be cirrhotic. You can look at their synthetic function, looking at their INR or their bilirubin and low albumin, but again, these are very end-stage abnormalities that only go up very late. And the same applies to ultrasound. So really what it means is that you need a more effective way of diagnosing or assessing fibrosis and diagnosing cirrhosis. We used to use biopsy, which is why ouch is written there. It was something patients absolutely hated. Once in a blue moon, we have to do it if there's confusion about the results we're getting, but in general, we don't do them anymore. And most of our assessment is done through a technique called Barber Scan, that I'll talk about in a moment. So this is what a Barber Scan machine looks like. What it is a machine that basically shoots sound waves through the liver, and the speed with which those sound waves go through the liver tell you how much scarring there is in that patient's liver. So on the right-hand bottom panel, there's an ultrasound technician who's got a probe. It's a bit like an ultrasound in the way it's performed. You find a rib space in the midclavicular line, and then you pulse the waves through. The only thing the patient feels is a slight tapping sensation as the sound waves go through. You need at least 10 valid readings, and if they're all close together and accurate, then you have a reasonably accurate assessment of that patient's fibrosis. And this, for the most part, is how we assess fibrosis. And most large tertiary hospitals will have a Barber Scan. So we at the Royal Melbourne have a mobile scanner, so we not only use that in the hospital, but we take it out to all sorts of other locations. So we take it to rural areas, we take it to drug and alcohol centres, and I think that's the way of the future. When you get a result from the ultrasound, it comes with a number called kilopascals, which is again the speed of that wave. And that roughly correlates to what you would get on a liver biopsy in terms of fibrosis. So this has been validated for hepatitis C, and what you can see, if you have a reading of 12.5 and above, that puts you in the cirrhotic range. So that's how we tell if someone's likely to have cirrhosis or not. It's particularly accurate in diagnosing cirrhosis and in diagnosing minimal fibrosis. It's not quite as accurate in that middle zone. And the advantages of a Barber Scan is that it's very simple to perform, it's very quick, it takes about 5 minutes. It's usually highly reproducible, particularly if you get the same person doing the scan, and you get pretty well an instant result. So for the first time, as opposed to when we had biopsies, you have ongoing prospective follow-ups of patients to monitor for fibrosis progression. So we can scan our patients every 1 to 2 years, particularly if they're waiting for therapy, which is what we did up until these new drugs came along. And it also allows for widespread screening for hepatic fibrosis in patients at risk of liver disease. So it's kind of revolutionised the way we assess fibrosis. Now, I'm mindful of the fact that not every place will actually have access to a Barber Scan. So the question is, what do you do if you don't have a Barber Scan? Now, if you're in Melbourne, you can usually refer into one of the centres, but if you're in a remote location, then you have to assess fibrosis in another way, and it's still important to do that. There are certain serum markers that are available, but those aren't really available in Australia. The one way you can do it is if you use the AST and the platelet count, and it gives you a score called an APRI. And if your APRI is less than 1, you can fairly confidently say that that patient doesn't have cirrhosis. And an APRA is calculated as such. You get the patient's AST level divided by the upper limit of normal of AST for that laboratory. You divide that by the platelet count and multiply it by 100. And that'll give you the score you need. There are several things that we do as clinicians when we're seeing a patient. What we like to do is try and get an assessment of the duration of Hep C infection, which you can often tell based on the duration of injecting history of that patient. Sometimes they've got a seroconversion illness, other times they have an acute hepatitis. So it's always worthwhile just getting a sense of how long that patient might have been infected. You need to know whether they've previously been treated and what the outcome of that treatment was, because that, as Alex will tell you, sometimes alters the way you treat the patient with the current drugs. You need to assess for cofactors for progression of liver disease, and that includes alcohol, hepatitis B, diabetes and obesity. If you're going to use ribavirin, which we occasionally use in certain of our treatment regimens, you need to know whether that patient is planning for a pregnancy, because ribavirin is teratogenetic. You need to consider vaccinations against hepatitis A and hepatitis B, and remember hepatitis B is free for people who inject drugs. You do look for physical and psychiatric comorbidities. You look for ongoing risk factors for viral transmission and reinfection, i.e. are they still injecting? That doesn't mean you don't treat them, but you need to know that they might be at risk of reinfection. And you take a complete list of their medications. As Alex will probably tell you, there are drug-drug interactions with some of the new drugs and other medications. So you need to know exactly what your patient is taking and whether it's compatible with the drugs we might want to give them. You do their physical examination, as I've told you. From a virological point of view, we always do their Hep C genotype and subtype. We do a quantitative viral load, and we do their other bloodborne virus serology as well as their hepatitis A serology. There's a whole bunch of investigations, most of which I've mentioned, so an FBE, blood chemistry, pregnancy test for women of childbearing age, a fibrosis assessment that I've talked about. An ultrasound should be done in everyone, at least as a baseline, and if they're cirrhotic, they need to have HCC screening 6 monthly for the rest of their lives. And if you're going to use ribavirin and they're more elderly and at risk, you probably should do an ECG. Now, I'm not suggesting you do all of these, that's what we do in the clinic, but at the very least, what we would like from you guys would be a genotype and a viral load and a set of liver function tests and an FBE. And if you're happy to do anything else, that's fine, but that's kind of the minimum that we would like from you. There are the general managements, obviously, because alcohol is a cofactor, you try to minimise alcohol intake. Dietary, everybody asks about diet. Dietary recommendations are as per general population. There is nothing specific that you need to do in terms of diet. Clearly, if they're overweight and they've got NASH, you need to try and reduce their weight, but there's nothing specific for Hep C itself. If they're injectors, you need to consider harm reduction advice. So remember that NSP and opiate substitution programs also reduce the rate of Hep C infection. So they will help if you're trying to reduce the amount of Hep C transmission as well as the new drugs, and I'll show you some data on that at the moment. You should consider vaccinating your patients, particularly for hepatitis B, and particularly if they've got ongoing risk of transmission. Hep A if they can afford it, but at least B is actually paid for by the government, and you need to screen them for other BBVs, and that means HIV and hepatitis B. The other thing people ask a lot about is disclosure. What is the obligation of that person to disclose? And the answer is, in most circumstances, there is none. You don't really have to tell anyone except for these particular circumstances. You need to tell someone if you're about to donate blood. If you're a healthcare or dental worker involved in what we call exposure-prone procedures, which you guys would not be, but it generally means someone who's putting their hand in a body cavity where they can't see it with a sharp instrument. Under those circumstances, you're obliged to know your bloodborne virus status, which means you need to know whether you're Hep C positive or not. The Defence Forces require disclosure, and certain insurance applications do as well. Remember, Hep C is a notifiable disease. Generally, the laboratory will notify it anonymously to the health department. The other thing I'd like to show you is a concept called treatment as prevention, and it's a concept that's come from the HIV literature. And what it means is that if you bring down the prevalence of a population enough, the rate of transmission cannot be sustained at that level and goes down. So this is some modelling done looking at injecting drug users and what would happen if you scaled up the amount of injectors that you actually treated and what would happen 15 years down the track at 3 different jurisdictions with different prevalences of Hep C. And what you can see, if you scale up to 80 patients per 1,000 injectors, which is not insurmountable, what you can see is the modelling suggests that in Melbourne and Vancouver and Edinburgh, you see a dramatic reduction in prevalence of Hep C. In the lower prevalence cities like Melbourne and Edinburgh, it goes down by 90%, and even in a higher prevalence jurisdiction like Vancouver, it goes down by about 50%. So therefore, one of the other things we're saying is that ideally you should try and treat active injecting drug users if it's feasible. Thanks very much.